afternoon, everybody, and welcome back to Experts on Air. My name is Caroline Brown from Hamilton Medical, and I'm very pleased to be kicking off this third series of webinars, this one about the many different faces of IntelliVent ASV. Today, we're delighted to welcome a Dutch team of Laura Buiteman and Jessie van Akkeren, and they'll start this series with the ABC of IntelliVent ASV. What is it? How does it work? What do you see on the screen? And why implement it in your ICU? For those of you not familiar with this format, your cameras and microphones are switched off, but we'd love you to ask all your questions using the Q&A function. Please don't be shy about asking questions, and we'll try to answer as many of them as possible during the webinar. The session is being recorded, and you'll receive a link to the recording after the holiday break. And now it's time for me to hand over to our interviewer for today, Jessie van Akkeren. Thanks, Jessie.
Thank you, Caroline, and thanks to Hamilton for organizing this webinar. And welcome, of course, to everybody to this first Experts on Air about IntelliVent ASV. I see we have quite a lot of visitors already. The fact that you are probably here means that you are interested, as we once were and still are, in automation and individualized mechanical ventilation. So we're happy to have you all aboard, of course. As Caroline already said, I'm Jessie van Akkeren. I'm an intensivist from the Netherlands. We have started IntelliVent ASV implementation about 5 years ago in our hospital and are still using it in most of our invasively ventilated patients. Well, it's a pleasure to introduce today's speaker, Laura Buiteman. Hi, Laura.
Hi.
Laura is an ICU nurse in the Renier de Graaf Hospital. Since about 3 years, she's a ventilation practitioner, and she's also doing her PhD research on IntelliVent and mechanical power. Laura will give a short presentation, and then we will have time to answer your questions. This webinar is meant to be as interactive as possible, so please post your questions. Don't wait until the end, and don't hesitate. I will not mention your name. For those who have participated in earlier Experts on Air webinars, there are always 1 or 2 poll questions. Today there will be 3, and at different time points in the webinar. So before we are going to Laura's presentation, our first poll question. And just to check, Laura, can you see it? Great.
Yes.
All right. Do you have any experience in using automation in mechanical ventilation? Well, the answers are simple. You can only answer give one answer. None, some, and it's part of my daily practice. Okay. And I will share the results now. That looks interesting. There's some experience for most. It's part of my daily practice, quite a lot of this audience, which is, by the way, quite large, and some none, but probably interested. So, Laura, anything to comment on this?
Well, it's nice to see always those answers. I think a lot of people, I hope I can learn a lot of people during this group about IntelliVent ASV. And I'm curious to the questions after my lecture.
Okay, so am I. It's time for the presentation. Yeah. So if you're ready, please go ahead. And there is the Q&A question that Caroline already mentioned. So during the presentation and afterwards, please post questions. Don't hesitate. Don't wait till the end. Laura, go ahead.
Thank you, Jesse, and good afternoon, everybody. It's great to start this Experts on Air session. So thanks to Hamilton Medical for the invitation, and thanks to Jesse for the introduction of myself. And I don't need to do that anymore. This is my disclosure. And today is about the basics of IntelliVent ASV. How does it work? What do you see? How to set this ventilation mode, and why should you use it? And it is a very sophisticated mode, but to use it, there need to be knowledge about all the settings, screens, and how to start with it. So let's start. Well, at my ICU, we started with IntelliVent ASV almost 3 years ago. I work in Delft, as Jesse already told, and that's a smaller city in the southwest of the Netherlands. And this picture here is a typical Dutch landscape. And I thought by myself that starting with IntelliVent ASV is comparable to this road. It's a beautiful road. It's a nice view, but it takes some time to discover it. And you don't know exactly where the road ends, because in Delft, we started 2 months before the COVID pandemic started with IntelliVent ASV. And although it was a challenge, of course, it was also a benefit because the whole ICU team used it in so many patients and so many times. So when the pandemic started, I didn't know where the IntelliVent road at our ICU ended, but it turned out to be successful. So IntelliVent ASV comes with targets, with algorithms, and with automated adjustments. The underlying basis is adaptive support ventilation, ASV, which is a closed loop ventilation mode, and IntelliVent ASV is the successor of it, an automated closed loop ventilation mode. With IntelliVent ASV, a target for ventilation is set based on the end-tidal CO2 measurement, and an oxygenation target is set based on the SpO2. And based on the target minute volume, the most optimal combination between tidal volume and respiratory rate is set by the ventilator. And this is based on the lowest work of breathing, according to the equation of Otis, and the lowest force of breathing, according to Mead, and also by means of the measurement of the expiratory time constant. This means that the settings are based on the individual lung mechanics of the ventilated patients. And for that, it requires also the gender and length of the patient for calculating the ideal body weight. PEEP and FiO2 are set based on the PEEP FiO2 tables according to the ARDS network trials, but it's also adjustable by the user, by us. An IntelliVent ASV is suitable for passive and active patients, and it adjusts settings 24/7. It increases support when patients are getting worse, but also decreases support when patients are improving. But of course, we as ICU doctors and nurses, we want to see how things work. And with mechanical ventilation, you just want to see the screen. And even better, you just want to feel it and touch it, but that's not possible in a webinar. But let's take a look, because I have a first movie to show what the screen looks like. So this patient is passively ventilated with ASV, and from here we set IntelliVent ASV. And in the first screen, we turn the controllers of the percentage minute volume, the PEEP, and oxygen to automatic, meaning that automated adjustments are turning on. And then you can also see that the controllers are turning into the black and blue color instead of the white and gray. And in the next screen, that's this, here is where you set the oxygenation and the ventilation targets. The target for SpO2, right here, is between 93 and 97%. And regarding the ventilation target, the CO2 elimination, the target is set from 36 to 43 millimeters of mercury. And with the buttons target shift, you can target a lower value by switching to the left, or a higher value by turning to the right. And there are also some limits to set. The oxygen limit is on the left, and that's to indicate how low the oxygen may be reduced to by IntelliVent ASV. And PEEP is set by a lower and upper limit, and between these values, IntelliVent ASV can adjust PEEP. And in this patient, we decrease the upper limit to 12. So by IntelliVent, PEEP cannot set higher than 12 and not lower than 5. In this screen, you see the controllers again with the black and blue on the right, and the already known settings, I think, of PRAMP and triggering, for example. And important and specific for IntelliVent ASV is the P limit, the pressure limit, which is the maximum airway pressure to how high the inspiratory pressure may be increased by IntelliVent ASV. So it's a setting to maintain lower pressures and the default setting is 30 centimeters of water. So setting alarm limits is comparable, I think, for now to conventional ventilation. And by switching to IntelliVent ASV, there are 3 tidal volumes to define lung mechanics and to set the initial settings by IntelliVent ASV. And after those first set of 3 tidal volumes, IntelliVent ASV is really starting. And here is it running with a percentage minute volume of 110, PEEP of 6, and oxygen of 34%. You see the CO2 elimination graph with the set targets and the CO2 waveform. And you see the oxygenation graph with also the target. And on the left, you see the dynamic lung, which indicates the resistance and compliance. And it's visualized with an image. And here there are 2 other ways to visualize the target shifts of oxygenation and ventilation, which I will show next in the next slide more about it. And what you can also always choose, and it's what I choose most of the time, is the ASV graph, which shows more about the settings of IntelliVent ASV, but I will explain this also in the next slide. So we already saw a lot of IntelliVent ASV specific screens and settings, but I want to focus on 3 things now, which is the end-tidal CO2 target with the ASV graph and the safety window, and something about the SpO2 target. So here you see the ventilation map with the end-tidal CO2 target. What you see is the target of 37 to 44. It's not just one value to target, because IntelliVent ASV needs some room to make the adjustments within the target. Most below you see the measured end-tidal CO2 of 40, and the green signal left to 40 indicates that the value is measured with a good quality without any failures of the CO2 sensor. On the left you see a measured peak pressure of 20. And probably the most remarkable thing is the funnel shape in the graph. It means that when the airway pressures are increasing, for example, to 30, the end-tidal CO2 target is slowly changing to the right, which means that a somewhat higher end-tidal CO2 is being targeted. And in this way, lung protective ventilation is applied during ventilation with higher pressures. And you see the value of 30 and the white shaded part below of it. And that represents the pressure limit, which was IntelliVent ASV specific, what we said earlier during setting of IntelliVent ASV. So here is the IntelliVent screen again. And here I show the ventilation controller in action. And what we see first is the dynamic lung here on the left with the lung mechanics. So what you see is a restrictive lung with a low compliance, which is a stiff lung. And you can see on the left part of the lung graph that we are ventilating a female with an ideal body weight of 60 kilograms. And then we go to the ventilation map, because here you see that the end-tidal CO2 is now measured of 47, which is higher than the target we set. So you see the percentage minute volume increasing. To increase minute volume, and then you reach the end-tidal CO2 target again. So you already saw the ASV graph with the safety window, and that's, for me, it's a very informative one. On the x-axis, you see the respiratory rate plotted, and on the y-axis, you see the tidal volume. And in this example, a minute volume of 6.6 liters is provided with a combination of a tidal volume of 424 and a respiratory rate of 16, which is, in this example, for this patient, the optimal combination of respiratory rate and tidal volume based on the lung mechanics. And you see the target here on the blue and white dot in the graph itself. And the red area represents the so-called safety window, which is the area wherein lung protective ventilation can be provided and wherein settings are changed in a safe area by IntelliVent ASV. So the settings are based on the lung mechanics of the patients, so resistance, compliance, and also the expiratory time constant measurements. But it's also based on lung protective safety limits to prevent for too much dead space ventilation, to prevent for auto-PEEP, and to prevent for a too high tidal volume, which can lead to a baro or volu trauma. So for me, the ASV graph is the most informative one because you can see at a glance what IntelliVent ASV is setting and why. In this screen, you see the graph again on the left, and with a minute volume of 8.3 liters for this patient with the restrictive lungs that we saw earlier. The optimal combination now is a respiratory rate of 25 and a tidal volume of 334. This is applied with an inspiratory pressure of 13 centimeters of water, and the respiratory rate of 25 are controlled tidal volumes. You can see that on the right of the ASV graph. And when the minute volume is increased based on the SpO2 target, you see in the graph that there is some room for increasing the tidal volume, because for this patient with the ideal body weight of 60 kilograms, this tidal volume with the restrictive lungs is somewhat below the 6 milliliters kilograms ideal body weight, but there's also some more room with the respiratory rate. So here you see the oxygenation map, where you can see the targets of 93 to 97%, a set PEEP of 6, and a measured SpO2 of 93 with a good quality of the measurement. 93 is somewhat below the target. And also you see the funnel shape again, meaning that if a higher PEEP is necessary, the SpO2 target will gradually be lowered to prevent for excessive use of FiO2, just to maintain that certain SpO2 setting. Because in injured lungs in need for high ventilatory support, it is most of the times more lung protective to target a somewhat lower SpO2. And I think we all use this approach in the clinical setting. And the red lines in this graph are the PEEP limits, which we set earlier during the setting IntelliVent ASV. So here you see the ASV screen again, and I hope it looks already more familiar because there's a lot you can see. And what we see here is that the measured SpO2 is 91, which is on the lower side of the oxygenation target. PEEP limits are set between 5 and 15, which are the red lines in the oxygenation map. And in this example, PEEP is increasing to reach the SpO2 target for increasing SpO2. And next to PEEP, you see, next to the PEEP controller, you see a countdown in seconds, which means that in 1 second, PEEP is increasing to 14. Well, this was a challenge showing IntelliVent ASV in a nutshell. Normally, I can spend days or at least hours explaining IntelliVent ASV. But important in this short lecture is that although automated ventilation is different from conventional ventilation, you as a user, as an ICU nurse or ICU doctor, you are always in control because you set the targets, you set the limits, and you can adjust whenever is necessary. But instead of being the pilot controlling the plane, you are supervising the autopilot, and of course that's different. To start with this in your ICU, it requires education and discussion in your team. And what I most of the time ask to my colleagues when there is a question about the ventilation, I ask, what did IntelliVent do and why? Because what and why helps to understand the settings of IntelliVent ASV and help gaining experience with it. But I'm sure there are a lot of questions, and I'd be happy to take any.
Okay, thank you, Laura.
You're welcome, of course.
Okay, okay. I was just checking if I'm on the screen. So we have some questions coming in, quite interesting ones also. I have one to start with. At first sight, this seems quite overwhelming. You've showed us a lot of things that you still have to set when you're using Intelligent ASV. It might look a little bit strange. We had the same experience, of course. We are talking about automation, and yet we have a lot of settings to do. Could you comment on that?
Yeah, well, that's true. There are still, of course, settings and limits you have to set, because don't remember that we as users, we are always in control, and we are supervising this autopilot, or we are supervising this ventilation mode. So before automation can start, we as ICU professionals need to define what do we want with this patient during mechanical ventilation. And well, then automation can start, but don't forget that you're always in control, and it's not that you could walk away and never come back to the room. But I'm sure you recognize that.
Yes, absolutely. It's the same with thermostats. It's freezing now, so happy to have a thermostat. Always happy that the pilot sets the autopilot before he turns it on. So of course, you have to set some things, but afterwards it's automation, of course.
Yeah.
Another question, in which kind of patients would you definitely not use Intelligent ASV?
Well, good question, because there are some formal contraindications of not using Intelligent ASV. One is during non-invasive ventilation, so with a mask or a helmet. Intelligent ASV is not suitable for that. And also in patients with a bronchopleural fistula, because there is too much air leakage, and Intelligent ASV cannot work with so many air leakage. Well, in my experience, patients with very irregular breathing or a neurologic respiratory drive, mechanical ventilation is always difficult, also with conventional ventilation, but well, it's the same with Intelligent ASV in those patients. Mechanical ventilation well, can be more of a challenge, but further in all patients, Intelligent ASV can be used.
Absolutely, I agree. So let's have a look. You talked about, if you showed us patients with that were passive, what to do when they are going to breathe spontaneously? Yeah,
well, that's a good question as well. Intelligent ASV is, as I said, suitable for passive and active patients, and well, the conversion from passive to active is a very smooth one, because I remember earlier when we just had conventional ventilation, so 4 years ago, that there was always a discussion when the patient was on a controlled mode, when do we set the patient on a support mode? And during Intelligent ASV, we don't have a discussion because it goes very smoothly, and sooner. It feels like patients are getting more active sooner. And during active patients, Intelligent ASV is basing the settings on the respiratory rate of the patients. Well, it's kind of an automated pressure support mode, but still with the principles of the lowest work and lowest force of breathing. Intelligent ASV adjusts settings, but then according to the respiratory rate. And the end-tidal CO2 target is more in the background.
Okay, thank you. Just to have some time that I can check the questions, I have a poll question to launch, the second one, and I will launch it now. Here it should be. And what do you see as being the obstacles to implementing automation in mechanical ventilation? And for those that are already using Intelligent ASV, what were the obstacles that you saw in the past? Was it safety, cost? I do not trust the algorithm, lack of flexibility, lack of scientific evidence, the fear of de-skilling, losing your skills, and it's difficult to implement. So you can't vote anymore, or you can, but it doesn't matter anymore right now. So I will share the results. Laura.
Yeah, what do we see? Well, I think the most remarkable answers are difficult implementation and descaling. And cost. Well, I will share my own experience regarding descaling, because I can't remember that we thought that when we wanted to start with IntelliVent ASV, but I was just curious about how can I work with this mode. And what we've noticed is that descaling is really not well, there is no descaling, because what you do when you supervise this mode is that your knowledge of mechanical ventilation, I think it even needs to be more than just with conventional ventilation. And at our ICU, there are more discussions about what did IntelliVent do, and well, I don't understand why IntelliVent is setting this. Can you explain it to me? I think there's more discussion and more thoughts about why is this are these settings set by IntelliVent ASV. And of course, we also use still conventional modes, study related, but also we use also conventional modes. So it's a combination of it.
Okay. Another interesting result, the difficult implementation, 47%.
Yeah.
Was it difficult to implement?
Well, we can share our story, I think, yes, because for implementation, of course, there need to be a lot of education. So we had a lot of education, just with a ventilator without a patient, but also bedside teaching. We had some experts on the floor, so they were trained extensively in IntelliVent ASV. So all those colleagues could support the rest of the team. But what we also have, and Jesse knows what I'm going to say, is that we had an external expert to help us during implementation. And this external expert was Jesse, because Jesse already used IntelliVent ASV for 2 years. So well, we got in touch, and Jesse helped me to give some master classes at our ICU. And when we started, we had a lot of contact about settings, and I asked Jesse, what is IntelliVent ASV doing? Do you understand? So in that way, I got an expert as well, because Jesse helped me. So that shows it's teamwork.
Yes, absolutely. So don't hesitate to ask other experts, and there are a lot of today to help you and to give simulation training or whatever.
Yeah, exactly.
So,
yeah.
Okay, how does IntelliVent deal with the increased dead space, which causes decreased reading of end-tidal CO2? So a CO2 gap.
The gap between the end-tidal CO2 and the PCO2.
I think.
Yeah.
Yes.
Well, what you can do when there is a gap, what we always do is checking the end-tidal CO2 with a blood gas. I think that's comparable to conventional ventilation. And when there is a gap, you can always adjust your target to target a lower end-tidal CO2. But sometimes the gap between end-tidal and PCO2 is too big. So IntelliVent ASV cannot overcome this. And then sometimes we switch to conventional ventilation for that moment. When the patient is improving, then we go back to IntelliVent ASV. But first, what you can do is check with blood gases, change your end-tidal CO2 target, and well, in case it's not working, then you can go to another mode.
All right. So check for one other maybe. Someone is thanking for the presentation.
You're welcome.
Is it safe using IntelliVent? What are your experience with it?
Well, good question. It is safe. I think I know that there are a lot of studies regarding results about safety already since 2012. And it is safe because before you start, you need, of course, to be sure that you know what you're doing. So you have to be trained well. But I think that applies to all new devices in the intensive care unit. And what I said earlier, it's not that you are starting IntelliVent, walk away and never come back. You need to remember that you are still in control and that you actually only leave certain settings to the ventilator, but you are always the supervisor. And
Okay.
or maybe it's nice to show one additional video about safety, and that regards about desaturation. What happens then? Because here you see a measured SpO2 of 84, and IntelliVent ASV is immediately increasing the oxygen to 100%, and gives also an alarm. So the user is warned. And when the SpO2 is increasing, IntelliVent ASV decreases oxygen immediately. So here's kind of safety alarms, but also safety setting. That when a patient is getting worse, oxygen is immediately starting to increase.
Yes. I'm convinced that one of our first patients is still alive because of this feature.
No, I think that we experienced this as well during the COVID pandemic.
Yes.
Yeah.
Okay, one last question before we go to the last poll question. How do you set PEEP?
Well, of course, you have the PEEP limits. And IntelliVent ASV sets PEEP according to the PEEP FiO2 tables from the ARDS network trials. But it's not that you need to blindly follow the algorithm. What we do with PEEP, how we set it, is based on the lung compliance and sometimes with an esophageal balloon catheter. And you always can limit your PEEP, because not in all patients you want to increase PEEP because you defined the best PEEP setting. And sometimes we also set PEEP to manual, so that IntelliVent ASV cannot adjust PEEP. But I don't know, what is your experience with that, Jesse?
Well, I believe PEEP, finding the optimal PEEP is always a delicate decision between too high or too low. I believe that when PEEP is not necessary anymore, it could be harmful. So for instance, in an ARDS patient, I will probably do first assess recruitability using a PV tool, which is on our ventilator. And when the patient is recruitable, I will recruit it with the PV tool. And then I will do a decremental PEEP titration to find the lowest PEEP before de-recruitment starts. And that will be the reason to set a certain PEEP limit. I don't want the PEEP to get much higher than necessary.
No.
So that and sometimes also the balloon, of course.
Yeah.
And compliance. Yes.
Yeah. Well, I think it shows that IntelliVent ASV is helpful, but that we are always in control of it.
Absolutely.
That we define the settings, and it's not that you just blindly follow what IntelliVent is doing.
Absolutely. Okay, that brings us to our last poll question, and I will launch it now. After this webinar, what do you think at this moment? Would you consider trying this ventilation mode if you haven't already, or will you keep using it? Because we have a lot of people using IntelliVent. It's a little bit surprising for us that there are so many.
Well, it shows that there are still more. There are more users.
Absolutely.
More than 3 years ago, I think.
Absolutely.
When we started. Yeah.
So we know it in our country. 5 years ago, it was a novum, and now it's not. Everybody's going to do it.
Yeah.
Well, you think sometimes. Okay. I think I will terminate this one, and then share the results. And you could see them now. A yes, for sure. Great. I might try it. Okay. Absolutely. Feel free to call. It's not for me. Always possible, of course. And not yet. I need to know more. And
yeah, that I can understand.
We have a lot of webinars coming up, and there's a lot of information, and you can always call people to explain several things to you. Well, unfortunately, I think we have come to the end. We are already a little bit over time, but it was very interesting. I thank you, Laura, for this presentation and for the interaction. Always nice.
Yeah,
and
agree. Thank you, Jesse.
Okay, you're welcome. And Caroline, thanks again for organizing this webinar, and the digital stage is yours, but only after I thank the audience for the interaction. There are a lot of questions. We couldn't answer them all, so we will try to do that and send you the answers per mail in the next weeks. Caroline, the stage is yours.
Thank you very much, Jesse. So that's a wrap for today, everybody. As always, a big thanks to all of you for attending, and a huge thanks to our 2 experts for sharing their knowledge with us. I would also like to apologize for my bad pronunciation of their names, because Dutch is not my strong point.
Oh, you did well.
Thank you. The link to the recording will be in your inbox in a few weeks' time, and we look forward to seeing you all again for the second webinar in this series on January 26th. Everyone who signed up for the series will automatically receive the reminders and information about future events in this series. If you're joining today using a link from somebody else, you can sign up very soon using the QR code that will be shown on the screen. And when you leave this session, there'll be a few short questions that we would really love you to answer. Thank you very much. And in the meantime, we'd like to wish you all the very best for the holiday season and a great start to the new year. Thanks a lot. Bye-bye, and see you again in 2023. And thank you to the experts again. Bye-bye.
Merry Christmas. Happy New Year.
Bye-bye.